Hi, I'm Mulheren, and I'm an intern in the Science Internship Program for Nursing. I work in the Center for Neurological Restoration. I'm going to be a senior at Brunswick High School this fall, and my project is on the effects of deep brain stimulation on the motor symptoms of Parkinson's disease. So to give you a background, deep brain stimulation is a procedure where electrodes are surgically implanted into a specific target of the brain to help treat motor or non-motor symptoms by electrical stimulation. And common places for this are the subthalamic nucleus and the internal segment of the globus pallidus. They can be placed either uni or bilaterally, and it all depends on the patient's symptoms. So DBS can reduce tremor, bradykinesia, rigidity, and gait impairment. And research has also shown that DBS may improve dystonia, Tourette syndrome, and certain disorders such as pain, depression, and obsessive-compulsive disorder, or OCD. However, these are not FDA-approved treatments, so they're only available through compassionate use. And the diagnosis determines the target in the brain. So to determine whether a patient will be a good surgical candidate, the patient must go through a rigorous screening process to determine if they're a good candidate. It's based on how they respond to Parkinson's medications and using the UPDR scoring system, or the Unified Parkinson's Disease Rating Scale. And they're videotaped on and off medications for review at a patient management meeting, which is a multidisciplinary team, and they ultimately decide on whether the patient's a good candidate or not. At this meeting, there will be a neurologist, a neurosurgeon, a psychiatrist, a neuropsychologist, a nurse, and a bioethicist. So in the surgery, a hole is drilled in the frontal lobe of the skull, and the electrode is inserted usually into the STN. It can be other places as well, but it's most commonly the STN, or the subthalamic nucleus, for Parkinson's patients. So in a couple weeks after the surgery, a second surgery takes place where the surgeons will implant the implanted pulse generator, or IPG, to the chest, and it connects to the electrode in the brain through a lead which is threaded underneath the skin. And this can be done at the same time of electrode placement, but it's really up to the judgment of the neurosurgeon. So 1 month postoperatively, the patient will receive his or her first programming. And it's done with a device by a clinical nurse specialist or any other trained personnel. And the programming device, it's connected to a magnet which sits upon the person's chest, and they can adjust voltage and other things until they can optimize the patient's improvement. So the purpose of my study is to determine the percentage of improvement in the motor symptoms of patients with Parkinson's disease before and after deep brain stimulation surgery at the Center for Neurological Restoration. So the data was acquired from patient records under the criteria that the patient had undergone DBS surgery in order to treat Parkinson's disease from May 2010 to May 2011. Motor scores are based on the Unified Parkinson's Disease Rating Scale, also called UPDRS scores, and they range from 0 to 108, where 0 is normal and 108 is miserable. They just can't do anything. And the average improvement is determined by comparing these scores from preoperatively to 9 to 12 months postoperatively. So the patients, it was taken from a pool of 30 individuals with Parkinson's disease, 24 were male, 6 female. 3 brain targets were in the GPI, the globus pallidus, 26 in the STN, and 1 in the VIM. The average age was 63.8 years. So the outcomes, as you can see, are preoperatively off medication at a score of 40.3, and at the final score, it's only 16.5, which is really major. It's a 59% increase, and the p-value is less than 0.00. So in conclusion, deep brain stimulation improves the motor symptoms of Parkinson's disease more than medication alone, and the improvement lasts through the end of at least the first year. Our recommendations and ideas for future studies are to repeat studies to ensure maintaining this level of excellence, and that all patients are asked to return at 1-year intervals. All patients also should get on-stim and off-medication UPDRS testing at the benchmark intervals of 1, 3, 6, and 12 months. And I'd just like to give my special gratitude to the Office of Civic Education Initiatives for giving us this great opportunity, my mentors, Catherine Wilson and Kevin McLaughlin, for all their guidance and support, and for the help of Dr. Milan Zagankar for his help with this project. Thank you.